Hello, everyone. Welcome to our talk on nephrology, renal medicine, whatever you want to call it. Just let last few people trickle in and then we'll begin. While that's happening, I'll just introduce myself. My name is Eamon. I'm the Mind the Bleep final year lead. Currently in F1, did cardiology, now doing gastro. Always quite enjoyed renal and have produced for you guys this presentation with another registrar, Dr. Mahideen, who is a lovely guy. He's checked through it all as well. Should hopefully be an hour. We'll have a few SBAs, a little bit about what's, the anatomy of the kidneys and the common things that come up in SBAs. OSCEs less so, but we'll try and hit OSCEs later on in the year with some various other lectures too. As always, if you guys have any questions, just pop it in the chat. We'll try my best to answer them. If not, then I'll get back to you later. And yeah, I think let's get going. So we've got an hour, and today what we're going to try and do is basically cover the main things that you're going to find from renal in SBAs. And that's going to be, first of all, AKI, CKD, and a little bit of glomerular diseases as well. We'll do some anatomy and function very briefly at the start, just so everyone's kind of familiar and the rest of the talk makes sense. The bits that we won't cover, but I think are really, really important, are renal replacement therapy, transplants, and diabetic nephropathy as well. We'll touch on them, but we're not going to cover them probably to the level that you will be tested on. So I would recommend that, from this talk, do a little bit of that other stuff in the background as well. We also have, I've drawn up the UKMLA condition map and presentation map. This is basically what they're expecting you to know. The key things, obviously, from a renal perspective rather than urology perspective, are AKI, CKD, diaphoretic nephropathy as well, nephrotic syndrome too. I think nephrotic syndrome kind of includes all the glomerulonephridities as well, which we will touch on today. Nice. So let's get going. The kidney generally is made up of a number of different layers, as you can see on the picture on the left. The outermost layer, there's a fibrous capsule, which kind of provides some protective layer, a protective element to the kidney. You then have the renal cortex, the renal medulla, and then you've kind of got all the little bits of minor major calyces, renal pelvis, and ureter as well. Generally, the majority of nephrons are found in the renal cortex, with the collecting ducts then going down into the renal pyramids. The renal medulla generally includes the renal pyramids and the renal columns as well. The renal columns are where you get the blood vessels. That's going to be your arteries and veins supplying all the blood to the nephrons and the glomeruli, where all the filtration happens. From the collecting duct, you then go into the minor and then the major calyx, and then you go into the renal pelvis and then into the ureter. So very basic overview of what the kidney involves. I don't think you need to know anything more really for exams. In terms of the nephron itself, now this is important, and the reason why this is probably important is because there's a clinical aspect to this where it helps to know where diuretics affect the nephron. The reason being, you can then work out what electrolyte abnormalities you should be expecting. So the most common ones that we use are furosemide. These are loop diuretics, and they work on the NKCC2 channel on the ascending loop of Henle. NKCC2 is sodium, potassium, chloride, I think calcium as well. But basically, you're going to get low in all of those different channels because you're not reabsorbing them, okay? So you get hyponatremia, hypokalemia very, very classically with furosemide. In the early part of the distal collecting tubule, that's where thiazides work. The later part is the spironolactone. The thiazides kind of work on the sodium chloride channel, and this causes increased potassium excretion as well. Later on, through the sodium potassium channels, we call spironolactone or other mineralocorticoid receptor antagonists. We call these potassium sparing diuretics because they actually don't cause hypokalemia. you've got spiroeplerenone as well, and these block aldosterone. So these are aldosterone receptor, mineralocorticoid receptor antagonists, and they kind of inhibit some of that RAS effect as well. Cool. A little bit about function, and this is important because when you get diseases to the kidneys, you can actually very easily work out what you're expecting, what you need to be testing for. Specific, I mean, there's loads of acronyms out there. One I've just picked up is a wet bed, and the different types of function to be aware of are acid-base balance. So if you get impairment in that, then you get metabolic acidosis typically. Water removal, classically, kind of we expect this. Patient not passing urine, then you become edematous, and often present with a patient who is, very overloaded, swollen, and anuric. The kidney is involved in erythropoiesis. It produces erythropoietin, the hormone, and this can present with fatigue, tiredness, and lead to anemia. An important function of the kidney is removing toxins. One of the main ones here that we're focusing on is urea. When you get high urea, then you can become pruritic, confused, you can get a flap, you can get uremic pericarditis, encephalopathy. So it's a very, very important complication to be aware of. Blood pressure control as well is crucial, and you can get RAS activation, so the renin-angiotensin-aldosterone system activation. When it shouldn't be activated, this can then cause hypertension. Electrolyte imbalances as well, so you can get hyperkalemia, and this can lead to arrhythmias and ECG changes. And one of the classic CKD complications is mineral and bone disease, and this can present as things like fractures, bony pain, and often you may see hyperparathyroidism as well. So, first SBA for you guys. I just saw Paul's message. Can't remember. Will these slides be available afterwards? So we'll put the talk up onto YouTube afterwards. The slides, we're struggling to kind of get them sorted. So screenshot what you want, but this talk will be put up onto YouTube afterwards regardless. All right. Cool. So let me just create a poll. Okay, so answer away. Quickly read you through it. 68-year-old lady presents to E&E with 4 days of worsening nausea and vomiting. Her blood show creatinine 156, baseline is 64, potassium 6.1, urea 8.7, sodium 135. Okay, routine bloods, and then her observations show she's quite tachycardic, normalish blood pressure. All right, last few responses. And stopping the polling. Oops, daisy. Okay, so 52% of people have chosen 1 and 47% of people have chosen 2. And that is generally the split that I was expecting. So what's going on here? This is a lady who has presented with 4 days of sudden or acute nausea and vomiting. Her heart rate is raised and her blood pressure is on the normal side. So you can suggest from this that she is slightly dehydrated, okay? Her blood pressure is holding, but she is tachycardic and she is vomiting a lot as well. So that all is risk factors for AKI, isn't it? And we know this is an AKI because a number of things. 1, her creatinine 2 months ago was 64. This is less than 3 months, which is not within, and more than 3 months is required for it to be CKD. So it's less than 3 months of quite a big jump, actually, more than double. A little bit of hyperkalemia as well, and the urea is typically high too. So everyone generally has been able to establish that you need IV fluids. They're dehydrated and they're hyperkalemic as well, so we need to do something about that. Generally, look at the question. The best initial management, you would not give calcium gluconate, one, without at least doing an ECG, and preferably, actually, they should be on cardiac monitoring as well, okay? So the first thing you will do is look for ECG changes. If there are ECG changes, then you will give calcium gluconate. If generally the algorithm says if potassium is more than 6.5, then you would also give calcium gluconate. But again, that can be argued otherwise as well. There are some doctors that would only wait for ECG changes. So that really is dependent up to the clinician. Probably be safest to give it, especially as an F1, potassium more than 3.5, 6.5, give your calcium gluconate. So Rajika's question, if it's more than 6.5, then you wouldn't do ECG. You would still do an ECG anyway, just what I just said. You want to look for ECG changes. And if there aren't, then, the inclination for you to give the calcium gluconate is less, but you can still give it. And yes, thanks, Rajat. We know that this patient is dehydrated because the urea is raised and they are tachycardic as well, with a known cause for dehydration, nausea, and vomiting. All right. Nice. So, AKI. AKI is defined by an acute decline in renal function, and this is either through a rise in creatinine or decline in urine output, with the table being over here on the right. Generally, stage 1 is 1.5 to 1.9 times, stage 2 is 2 to 2.9, stage 3 is more than 3 times, with a few other different caveats. Or look at the urine output as well. I'm not going to read them out to you, but I would be very familiar with this table. I think it's an important table and does come up in exams. At least I did in ours in terms of being able to stage an AKI a little bit as well. All right. And generally, we classify it into 3 types. I'm sure you know: pre-renal, intrinsic, and post-renal. And we'll just talk a little bit about all of that individually. Ashok, so the first option is correct then for the SBA? Yes, sorry. So we always want to do IV fluids and ECG, okay? That's the best initial management. Once you've done that, then you would start the calcium gluconate. So, pre-renal AKI is caused by decreased perfusion to the kidneys. And generally, what people assume is it's hypovolemia, i.e. someone is very dehydrated, but it is important to also consider hypertension, and there is a distinction between the two. Hypovolemia being lack of fluid in the blood vessels, and hypertension being a low blood pressure. Subtle, but there is a difference, and I'll talk a little more about that. So if someone is hemorrhaging lots of blood, they're losing fluids in other ways, such as vomiting, diarrhea, sweating lots, or burns, we get huge extravasation. This can also cause reduced fluid in the blood vessels. This then causes reduced perfusion to the kidneys, and that in itself causes damage, raising the creatinine and reducing the amount of excretion that you can get from the blood vessels. Hypotension is a little bit different. And for example, take heart failure, okay? If someone's got heart failure, you have a poor ejection fraction, a poor cardiac output, and this then causes backlog of blood into the venous congestion. So actually in the blood vessel, there's a lot of blood, but the blood pressure is low, and that in itself is causing decreased perfusion to the kidneys, okay, because your cardiac output is inefficient. So there is a slight distinction. Another thing to consider is renal artery stenosis. This is where the main artery supplying the kidney is blocked, not fully blocked, but often the lumen can be reduced in size. When that happens, the kidney thinks that there's hypovolemia because, well, it's getting reduced supply, and then acts as such, and you get a pre-renal AKI. Other drugs are also important, so things like NSAIDs and ACE inhibitors we all are aware of. Often it's confusing to remember which one does which. NSAIDs cause constriction of the afferent arteriole. What this does is similar to renal artery stenosis. You get reduced perfusion to the glomeruli, and the kidney thinks that it's hypovolemic. ACE inhibitors reduce constriction of the efferent arteriole. And what happens is when you the excretion of all the waste products from the blood is effectively through the difference in pressure between the efferent and the afferent arteriole. And if you're reducing constriction of the efferent arteriole, well, then you're decreasing that pressure gradient, and you've got reduced. We're taking out fewer waste products from the blood due to that. Next type of AKI is an intrinsic AKI. This is where you get severe direct damage to the kidneys. Acute tubular injury is the commonest, and we'll talk about that. But other things are also glomerular diseases, which we'll have a section to itself later, and also acute interstitial nephritis. So, acute tubular injury used to be known as acute tubular necrosis. So often in notes, you'll see both in questions. You might see both as well if they haven't been updated. I know my med school wasn't. What happens here is you get damage to the epithelial cells in the tubules of the nephron and the kidney. And these then necrose and slough off, kind of blocking the tubule lumen, okay? Typically, this is caused by two main different categories, either ischemic or nephrotoxins. Ischemia, where let's say you have a prolonged prerenal AKI and you're decreasing perfusion to the kidneys, this in itself, whilst causing an AKI, can actually also, reduce blood supply to the tubular cells, which are actually some of the most energy hungry cells in the kidney, and these are one of the first to die. These then fall off effectively and necrose, blocking the tubules and causing muddy brown casts, which is pathognomonic of acute tubular injury. Okay, so in a question, if you ever see muddy brown casts, always think acute tubular injury. The other main cause are nephrotoxins, and there's quite a few of these. Often we think of things like gentamicin, contrast dye from CT scans, etc. But also think about rhabdomyolysis, hemolysis, and raised uric acid. So in patients, for example, who have a history of gout. In those three diseases, you often also can see acute tubular injury, and it can be quite common. Okay. I've put here reduced reabsorption of water, urea, and sodium. We'll come to that a little bit later, but it's helpful in differentiating really acute tubular injury from prerenal AKIs. And acute tubular injury is not easily reversible. It's quite hard to treat. Generally, just give supportive management. Acute interstitial nephritis sounds very similar, but actually is quite different in terms of what's going on. With this one, always think an allergic reaction to the kidneys effectively, okay? And this is how it will present generally in your SBAs. The four things to remember are if you get an AKI with a fever, a rash, and eosinophils in the urine, then that's it. This is going to be acute interstitial nephritis, okay? Often it's a type 1 or type 4 hypersensitivity reaction, so IgE or cell-mediated, can be caused by drugs such as those that we've got there, diuretics, NSAIDs, penicillins, PPIs, anti-epileptic drugs, sarcoidosis, and also a number of infections can also cause acute interstitial nephritis. Remember, your symptoms are always pyrexia, rash, and although typically people say eosinophils in the urine, that is apparently in clinical practice a bit rarer, and generally what you do see is white cell casts in the urine, okay? So in an SBA, if you see raised eosinophils in urine or serum with a patient with AKI, fever, and rash, think acute interstitial nephritis. In real life, if you don't see the eosinophils in the urine, that doesn't necessarily mean that's not. Look for white cell casts too. Treatment for this is to stop the drug, give supportive measures, give steroids as well. Okay. I've got a little bit on the urea creatinine ratio, and now this is not necessarily something that gets used a lot, but you do hear it on the wards, and it's kind of just you don't need to know it effectively, especially not for exams, but it's useful to be aware that in a dehydrated patient, so i.e. a pre-renal AKI, you're more likely to get a increased urea to creatinine ratio in the blood, i.e. urea goes up higher in dehydration, whilst a renal AKI actually is going to be a much lower urea. Okay, if you look on the right, this table, I don't know if you can see my mouse, so if someone can let me know if you can. If not, don't worry. Oops, sorry. But if we look at the differentiations between pre-renal AKIs and acute tubular injury or necrosis, there's a few things to note here. In pre-renal AKI, you're dehydrated. Your body is trying to reabsorb as much fluid as possible, and we reabsorb fluid as it follows the sodium. So we're going to reabsorb lots of sodium, lots of fluid, and therefore in the urine, you're going to get a low sodium in the urine. All right. Likewise, you're going to get a high osmolality in the urine because you reabsorbed as much as possible. However, in acute tubular injury, the cells that are reabsorbing are damaged. So you're going to get quite a high urine sodium and a low urine osmolality because you're not able to reabsorb much fluid. Okay? And that's a helpful distinction between the two alongside the urea creatinine ratio. Right. Then the other third main classification of AKI are post-renal AKIs. And these are effectively where you get obstruction to the urinary tract, and these can be through extrarenal or intrarenal causes. Extrarenal typically are more common, so things like BPH, tumors, retroperitoneal fibrosis, whilst intrarenal can be things like renal stones and blood clots. I'll explain after this slide, Afia. So generally, if someone has an acute retention of urine, that's going to be very, very painful, okay? And that's a helpful way of differentiating whether it's chronic or acute. If you get complete obstruction, then you're going to be anuric. So, just generally ask, are you even passing any urine? And the key diagnosis to a post-renal AKI is ultrasound. Here, we're looking for hydronephrosis or basically increase in the size of the ureters, okay? If you see those, then you can expect that there is a blockage somewhere. So note, you're not looking for actually the thing that's blocking the urinary tract. You're looking for signs that the tract is blocked by swelling of the upstream segments. This doesn't, however, exclude a blockage. Okay, and there are cases in the literature, etc., where actually post-renal AKIs have been missed because of this. Treatment generally is treat the cause. So, for example, if you have BPH and you need to treat that, if you have a tumor, then going down the tumor treatment route as well. In the meantime, well, it depends on where the blockage is, but often catheterization can help if it's things like BPH. If it's a bit of a higher up blockage, then you can consider things like percutaneous nephrostomy or an endoscopic ureteric stenting. This is where you kind of go through the urethra, put a stent into the ureter, and open up that way. After with the sodium bit, so in a pre-renal AKI, you're very dehydrated. Your body is trying to reabsorb as much fluid as possible. Fluid follows sodium, so your body is reabsorbing the sodium and the fluid is following that in with it. Therefore, in the urine, you're going to have very low sodium in a pre-renal AKI and a high urine osmolality because you reabsorbed as much fluid as possible. In acute tubular injury, your sodium is you're not able to reabsorb as much sodium due to damage to the lining of the tubular cells, the tubular epithelial cells. This means that actually there's quite a high sodium in the urine and a low urine osmolality because you're not able to reabsorb as much fluid as you'd like. Okay, so that's a helpful distinction in just trying to work out the differences between two different causes of AKI, which actually have a very similar presentation. Cool. So AKI investigations, remember, always split into bedside, laboratory, and imaging. Bedside are basic stuff, so a urine dip, a urine ACR, so albumin creatinine ratio, an MCS if you're worried about an infection. Consider doing urine electrolytes and osmolality, and that again will help you with what we just described in terms of differentiating pre-renal and renal. A bladder scan can be helpful as well. This is a bedside test. I don't know if you guys have seen it done. It just tells you how many mils is in the bladder. If it's a lot, you might consider a post-renal blockage such as BPH. Then do your bloods, your basic bloods, and imaging such as your ultrasound KUB are helpful to, again, look for blockages. Renal biopsy is the gold standard. If you have causes such as glomerulonephritis causing your AKI, this is where you're going to pick it up. Now, generally for most patients, it won't get to this stage, but if you're at a tertiary center, you're more likely to get it done. And yeah, it's generally the best way of working out what the cause of this AKI is. In terms of management, I use the acronym STOP AKI. I think I got this from BMJ Best Practice, but what it is effectively query, is there a septic screen required because sepsis can cause dehydration or reduce perfusion to the kidneys? Okay, good question, Paul. We'll get there. Then look, what drugs do you need to stop? So what are the toxins that you're giving? Okay, things like NSAIDs, ACE inhibitors, aminoglycosides, contrast, etc. Try and reduce as many of these as possible. Optimize patient's fluid status. And again, this comes down to what we were talking earlier about hypovolemia versus hypotension. Do you need to give someone fluids? Do you need to give somebody diuretics? Okay, because if someone's got heart failure, you're going to give diuretics, and fluids will actually worsen the problem. So this is why I was making that distinction earlier. And the last one is P, prevent any harm. So treat any reversible causes, manage any complications. Bianca Crowder, is there a feedback form? Yes, there is. I think I've just sent it. Paul's question, what happens? What would you do first? Do the bedside investigations first, okay? Generally, that's the best thing to do in any exam question. So that's for here, it would be a urine dip, ACR, MCS, etc. And consider a bladder scan as well, okay? Then you want to do, but the difference is here, typically if you're suspecting an AKI, it's because not necessarily the patient's symptomatic, but because actually the user needs have come back erroneous, because often AKI is asymptomatic unless it's quite bad. So, yeah. Dr. Addy's question is, have more prevalent in women, and given the hypertensive treatment potency of angiotensin receptor necrotizing inhibitors, treatment with diabetic hyperkalemic treatment resistant hypertensive females clinically benefit from Entresto in the absence of systolic heart failure, especially since it lowers HbA1c. I mean, I don't know. That's a very specific question. And also more cardio than renal. Sorry about that. Yeah. I'm not able to help there, Dr. Addy. Sorry. Okay. So AKI complications. One of the most feared ones, one of the ones that actually is probably an emergency that we need to definitely treat as soon as possible, is hyperkalemia. Okay. And I would, especially for exams, be very, very familiar with this treatment algorithm. So someone's hyperkalemic. As we said earlier, we need to do an ECG. If we can, we're going to put them on a cardiac monitor to monitor them. And if they've got ECG changes, if their potassium is more than 6.5, then we'll consider calcium gluconate. Okay, this is going to be 10 mils, 10% calcium gluconate. And this is cardioprotective. So the point of this is you're protecting the cardiac membrane, you're stabilizing it and reducing the risk of an arrhythmia, which can be life-threatening in hyperkalemia, okay? In terms of the ECG changes that you're looking out for, they can be found in this little life in the fast lane diagram I've got in the top right corner. You get initially peaked T waves. This is the first signs of hyperkalemia, but then you can also get P wave flattening, PR prolongation, and a wide QRS complex. Eventually, that can become quite a sinusoid pattern. So it looks like a sine wave going up and down, and that's where you're in real bad territory, and you need to kind of urgently treat this hyperkalemia. The other thing is insulin dextrose. And actually what I found out making this PowerPoint is the insulin is only given if your patient's diabetic. If you just give dextrose, then actually the patient produces endogenous insulin themselves, and insulin increases the shift of potassium from extracellular to intracellular spaces, therefore reducing the amount of potassium in the blood. So that's quite interesting. Not everybody actually needs to be given insulin. Salbutamol works in a similar manner. The key thing to note about insulin dextrose and salbutamol are you're not actually reducing the amount of potassium within the body. You're just moving it from one space to another to effectively reduce the impact on the heart. Okay, so it's a temporary measure, and it's something to keep an eye on definitely in the future, that the high potassium might still come back. Cool. Furosemide, its indication in AKI is a little bit more contested. It's given in hyperkalemia, it's a little bit more contested, given less commonly, often because patients are dehydrated, especially if they're pre-renal. But furosemide does increase potassium excretion. Likewise, metabolic acidosis, sometimes sodium bicarb is given. Again, that's a bit debated in the literature. And pulmonary edema, so where you've got your fluid overload, is treated like you've got heart failure, diuretics, oxygen, sit them up, give them CPAP if need be. Okay. Rajika's question, if urine sodium is high in ATN, surely the urine osmolality should be high too because you have more sodium in the urine. Yeah, so the thing about that is yes, but you've also got lots of fluid in the urine that you haven't reabsorbed, and that makes more of an impact on the urine osmolality. So ultimately, it's when you're reabsorbing the sodium in a pre-renal AKI, you'll get a whole gush of fluid coming with it, and that really concentrates the urine. But if you don't reabsorb that urine like you do in ATN, so that you're not reabsorbing that fluid in the urine, then actually you get quite a low urine osmolality because it's very dilute, even though there is still lots of sodium in there. I hope that makes sense. I think basically the answer to that question is the fluid makes more of an impact on the urine osmolality than the sodium. Yeah, basically. Cool. And indications for renal replacement therapy. Now, there are some cutoffs here. For example, people say acidosis, pH less than 7.2, but clinically they're used less frequently. But the nice little acronym to use is AEIOU, all your vowels. A standing for acidosis, which is refractory. So it's not you're not managing to raise the pH back up. And again, the numbers thrown around are 7.2, pH 7.2, but yeah. Electrolyte imbalances, again, refractory hyperkalemia. You've tried to bring it down, but you can't. Again, the number here is 6.5, but clinically less relevant. Intoxication, so if you've got lots of drugs in the blood that need to be removed. Edema, so they've got refractory overload. You've tried diuresis and then you try getting this fluid off and you can't. And uremia, causing end organ complications such as pericarditis, encephalopathy, etc. These are all reasons why you would do renal replacement therapy. Okay, so our next SBA, let me create a poll. Okay, I'll give you guys 30 seconds. Okay, 10 more seconds. Get your answers in. All right, 5, 4, 3, 2, 1. Okay, stop the poll. Poll's closed. So, a bit of a mixed bag here. 41% have gone for secondary hyperparathyroidism. And then a bit more of an even split between answers 2, 3, and 5. So, what do we have here? Here we have a 70-year-old male, so he's, quite an elderly gentleman, who's presented with a wrist fracture from not a high energy impact. Yeah. So he's just slipped from his sofa to the floor. He also has generalized bony pain for a few months. That's important. He's got CKD, likely secondary to diabetes, and his bloods show he's anemic. His eGFR is very low. Potassium is normal, but on the higher side. He's got a raised calcium, a raised phosphate, and a raised parathyroid hormone. And what we're asking really is, which complications is he suffering from? Well, he's suffering from anemia. That's one we know, but that's not an answer here. The other one is there's something going on with his potassium, his calcium, phosphate, and parathyroid hormone. With parathyroid hormone, there's your primary, secondary, tertiary. Primary, your parathyroid glands are producing loads and loads of hormone. Here you get, and that's the problem. That's where that's what's causing the issue. In secondary, it's in the name, kind of. Your calcium is low, and it's the low calcium that then causes an increase in hyperparathyroid excretion from the glands. In CKD, what typically happens is your calcium is low, and this is due to a lack of activated vitamin D being produced. Because of the lack of activated vitamin D, a lot of the calcium then has to come from parathyroid hormone. So your parathyroid glands go into overdrive. They start producing lots of the hormone. This causes lots of bone resorption and lots of calcium getting released into the blood that way. However, at some point, your parathyroid hormones go into such a state of overdrive that actually they completely decouple from the calcium levels, and they're just constantly pumping out as much hormone as possible. And at this stage, you become hypercalcemic and hyperparathyroid hormone as well. And that is a late stage complication of CKD. So the answer to this question is going to be number 5, being he's got a high calcium and a high parathyroid hormone, and therefore he's got tertiary hyperparathyroidism. And this brings us on to CKD. Right, so defined by abnormality in kidney structure, has to be more than 3 months. That's really important. So you need to do 2 blood tests more than 3 months apart. eGFR less than 60 or markers of kidney damage. Typically, we use ACR, albumin-creatinine ratio. That table there you can see on the right. I'm not going to go into it for time's sake, but do become familiar. Do become able to diagnose on stage CKD depending on the numbers, okay? The causes generally are, well, diabetic nephropathy is a big one. Hypertension is a big one. Glomerulonephridities, which includes IgA nephropathy, is a big one. But actually, often we don't even know the answer of why a patient has CKD. So it's very, very varied, very, very broad as well. Remember things like polycystic kidney disease too. And a patient with CKD often actually won't have any symptoms really, okay? It's only when you get to the very late stages when all these things like fatigue, edema, etc. come along. And here you've got the symptoms, with the cause. So if someone's fatigued, it's likely due to low HB, but also it could be due to uremia, edema because you get reduced urine output, causing salt and water retention. You can become uremic, again, which causes pruritus and also anorexia and nausea too. So it's the uremia that really causes a lot of problems here. Another important distinction to make is being able to differentiate CKD from AKI. A good way of doing it is through an ultrasound. If you look at the kidneys through imaging, then you can see actually in CKD generally you get smaller kidneys The one exception to this being diabetic nephropathy, where at the early stages, you get very large kidneys, very swollen kidneys, and then they start to shrink later on down the line. The other thing is in CKD, endocrine function is impaired, okay? And this is what leads to your anemia and your CKD and your mineral and bone disease. The other thing is, if you have a patient with a urea of maybe 30, 40, it's sky high, and they're just chilling, they're not encephalopathic, no encephalopathy whatsoever, that's a sign that actually they've had this high urea for a very long time, and that is probably CKD. Investigations are very similar to what we said for AKI. I'm not going to go into them too much. Note the bone profile. We want to be looking at parathyroid hormone, calcium, etc., because that is a complication of CKD. And, I think I've spent a lot of time talking about this slide before we've even got here, but I think that's because this is really, really important, okay? The complications of CKD are sodium imbalances. So often you get fluid overload, and this is because you're retaining lots of fluid and lots of sodium, treated with diuretics and a low salt and a diet. You can also fluid restrict as well, but that's uncomfortable for the patient, especially long term. You can get hyperkalemia long term in CKD. Often patients can become a little bit more tolerant to hyperkalemia. This is again treated with dietary restriction generally. Other things like Lokelma have come into play, and they're very good drugs in actually helping with hyperkalemia. Then you can get metabolic acidosis. This can be long-term. Again, sodium bicarb can work. I think it's a little bit more debated. And we have further information on the last two upcoming. Dr. Addy's question, reduced urine output in AKI. Yeah, you get reduced urine output in AKI. Yeah, you do. So Rajika's question, what is the reason behind hyperkalemia, and do you also get hypernatremia too? So the kidneys are involved in reabsorbing sodium and excreting potassium. Okay, so when you get damage to the kidneys, you're excreting less potassium, and therefore you got more potassium in the serum and you get hyperkalemia. So you wouldn't necessarily get hypernatremia as well, if that makes sense. Okay. Cool. So another big complication of CKD is anemia. Typically appears when you get eGFR less than 35, and it's because you're producing not enough erythropoietin. The main thing here is, I think, you kind of learn CKD, anemia, EPO. Don't do it necessarily. Always replace iron if iron deficient. So if you get a question that says, what's the first thing you do? Iron, or at least test for hematinics first and look to see if they're iron deficient. Okay. Then, if you do a cost-benefit analysis and a risk-benefit analysis, and you think, well, EPO will help with quality of life, then fine, you can give it. But there are a number of side effects. It can cause hypertension. It makes the blood very viscous, so you can get strokes, MIs. It can cause recurrence of cancer as well in those who've had it previously. So, we don't give it lightly. There is a analysis to be done for every patient that does get it. And always replace iron first. Then you've got mineral and bone disorder. The key thing here is it's caused really by two things. One, decreased activated vitamin D. Okay, this then causes decreased calcium absorption and overstimulate, and decreased calcium causes parathyroid hormone to go up. Likewise, the kidneys are involved in excreting phosphate. And similarly to potassium, because of that, when you get kidney damage, you're excreting less phosphate, and phosphate in the blood goes up. Raised phosphate also causes parathyroid hormone, or stimulates parathyroid hormone release. The combination of these causes bone reabsorption. You get bone pain, you get weak bones, easily fractured. The treatment for this is low phosphate. Give activated vitamin D, especially the vitamin D is low. Consideration of phosphate binders. so reduce the phosphate in the blood, calcium mimetics, which effectively mimic calcium and reduce parathyroid hormone stimulation. And in specific cases where, it's gone quite far down the line, you've tried other treatments, the patient might have tertiary hyperparathyroidism, then you can consider a parathyroidectomy. In terms of management, well, it's often really depends on where we are in terms of how bad the CKD is. If there's a cause, identify and treat it. So if someone's hyperglycemic, got very bad diabetes, treat that. Hypertension, treat that. Glomerulonephritis, try and treat that. Problem with things like diabetes, diabetic nephropathy, is once you've got it, it becomes a self-fulfilling prophecy. And even if you treat the diabetes, the proteinuria and all the damage that you get from that can really worsen kidney function itself. So it's very hard to treat once it's already begun. Stop any nephrotoxics. You want to try and protect the kidneys as much as possible. And dietary modifications is really important. So things like a normal protein diet, but low phosphate, low potassium, and low salt is crucial. And actually, this could be something like a OSCE scenario, to be honest, where you have to talk to a patient about and counsel them really about how we're going to treat their CKD in terms of lifestyle measures as well as medicines. Often, give them statins. You want to control their blood pressure. ACE inhibitors are very good, especially in anybody with proteinuria. Vaccinations, pneumococcal influenza. And when somebody hits stage 5, so eGFR 15 or less, then we go for consideration of dialysis or transplant. These are the ultimate treatments for CKD. Sorry, I'm rushing a little bit. We're just running out of time. Want to get you guys out on time. In terms of dialysis, two main ones very briefly: peritoneal hemodialysis. Peritoneal can be done 2 ways, either overnight or kind of while you're walking around. Can be performed at home, so it's good for people who are quite active in their lives, don't want to spend 3 times a week coming into clinic or into hospital. You insert a catheter into the abdomen and you use the peritoneum as the exchange membrane. With hemodialysis, you go to hospital 3 times a week. Long-term requires an arteriovenous fistula, although if it's an acute scenario, then you can do things. You can insert lines and get around that elsewhere. Arteriovenous fistula requires a surgery as well, okay? And it uses an external membrane for gas exchange or for exchange of waste products. A little bit about kidney transplants. The best kidneys are those from living donors. These last the longest and have the lowest rates of rejection. Then it becomes donor after brain death and then donor after cardiac death. It's not an option for everybody, but it is generally the best treatment and it will provide the best kidney function for you long term. Okay. The issues are, 1, not everybody is fit for the surgery. If you've got very bad CKD, likely you've got a whole number of different comorbidities, which makes you unable to tolerate surgery. And also you have to be able to tolerate immunosuppression lifelong. Okay, so for example, if your patient isn't going to be compliant with the medications and, has a very sketchy record in the background, then you might not consider them for a renal transplant. But again, it's a very nuanced decision. No one's going to expect you as a medical student or an F1 to be doing that. Okay, next question. I'm going to make a poll. Okay. And I'll give you guys 20 seconds. Only 3 responses so far. Okay, whole host have come in. Last 3-4 seconds, get your answers in. Closing the poll, closing the poll, closing the poll. Great. Okay, fine. So, I don't know if you can see the results. I hope you can. 68% of people have gone for 3. So the majority have gone for 3, with a few scattered going for 1, 2, and 4. Really good job. 3 is the right answer. Well done, guys. So this is a patient who is a 42-year-old European woman with cancer. Generally in an SBA, any information you're given is relevant. They've developed sudden onset peripheral edema of her face, legs, and abdomen. Okay, so generalized edema. Noticeably, it's not gravity dependent. So things like heart failure, it starts in the legs and works upwards. Here it's her face as well and abdomen. So it's kind of, less likely to be something like heart failure. Lots of protein in the urine. Albumin is low. You've hit your triad of nephrotic syndrome, haven't we? Now, with nephrotic syndrome, let's look at our answers. Well, actually, good pastures is not. It's nephrotic. Minimal change is nephrotic. Membranous is nephrotic. Lupus is nephrotic. And IgA nephropathy is also nephrotic. So just from that, we can really rule out 1, 4, and 5. We know it's going to be 2 and 3. The key thing here, actually, is minimal change disease can occur in adults. It's kind of glossed over. You will always think children, but it can occur in adults, and it's fairly common in adults as well. However, this is a European person with cancer. And when you see malignancy and glomerulonephritis, do think membranous nephropathy, because often, malignancy is a big risk factor for membranous nephropathy. Okay, so number 3 was correct. Well done, guys. Now, this is a good slide. I would screenshot this. I'm not going to talk you through it. But what it does do is it helps you understand some of the terminology behind the names we're giving these diseases. So, for example, focal sclerosing glomerulonephritis. Focal means less than 50% of the glomeruli are affected. Sclerosing means you've got scarring of the glomerulus, and then you have a glomerulonephritis. Okay, I would just pore over this, kind of get a bit familiar with it. It can help with some of the histology as well. And I don't know if that comes up in your SBAs or not, but it did in ours. Other thing to note is glomerular diseases can be primary or secondary. Secondary meaning it's caused by another disease process. So, for example, lupus or diabetic nephropathy. Right, now nephrotic versus nephritic syndrome. People generally tend to be very comfortable with nephrotic syndrome. It's your, the triad people know. So hyperalbuminemia, proteinuria, and edema caused by reduced oncotic pressure. Other things to be aware of, and this is helpful when looking at complications of nephrotic syndrome, are you get hyperlipidemia, you get loss of antithrombin 3, which means you're at increased risk of venous of VTE, so DVTs or PEs. You get loss of IgG, so also you're at an increased risk of infection as well. Okay. Nephritic syndrome, you use less frequently, less important to know, but generally you get your hypertension, your hematuria, an AKI of oliguria, red blood cell casts in the urine as well, some mild features of nephrotic syndrome. But the main thing here is hypertension, hematuria, AKI. Now, to be honest, I didn't think I knew much more than this slide for my finals on nephrotic syndromes. Minimal change disease, it's the commonest disease, glomerulonephritis in children. You get podocyte effacement seen in an electron microscope, whilst in a light microscope you don't see anything, and 90% are idiopathic. Focal segmental glomerulosclerosis can be split into primary versus genetic versus secondary versus undetermined. This is a new classification. Secondary often is caused by things such as viruses or drugs. Often in the stem, you will see something about men or Afro-Americans, and it's actually quite bad. 50% of people will develop end-stage renal disease in a few years. Membranous glomerulonephritis, what we just had. Now, this one is kind of really expanding the past few years in terms of number of antibodies we've found. So typically, what people know is anti-PLA2R. I would remember that one. That's the big one. But there are these other ones here that are all very new. Can also be caused by infection, malignancy, especially renal cell carcinoma, and drugs like gold as well. Often has an insidious onset, and you can remember the prognosis in terms of thirds. 1/3 have go into remission, 1/3 develop chronic glomerulonephritis, and 1/3 develop end-stage renal disease. The good thing about nephrotic syndrome is generally there is a generic treatment plan or pathway, okay? We're going to salt restrict, fluid restrict. If they're overloaded, then furosemide can help. And other things such as ACE inhibitors, statins for the hyperlipidemia, anticoagulation is really important because remember that risk of VTE, and consider steroids. That maybe depends a little bit more in terms of what the disease process is. Complications we've spoken about earlier, but they are venous thromboembolisms, MIs, strokes, renal vein thrombosis, CKD, recurrent infections, hyperlipidemia. So you're getting venous and arterial clots become very hypercoagulable. Okay. In terms of nephritic syndrome, it's not used very frequently anymore. Typically involves these 5 that we've got here, and we'll talk very quickly about them. 2 of the most common ones that I know, especially on PassMed, there's a whole load of questions. Is the reproduced renal function biomarker cystatin C independent of body mass more reliable than GFR indicators that rely on creatinine, giving false reassurance, apparently. So cystatin C it can be used when you are expecting problems with the creatinine, so where you're expecting creatinine to not be representative of a patient's renal function. Again, that can be in patients who are very thin or not eating very much, or big bodybuilders as well. Then you can consider using cystatin C. That is an alternative, although generally we do use creatinine and eGFR from that. Okay. I wouldn't say it's more reliable though, although I am not sure on that, to be honest. Rajika's question: how do you know which is nephrotic? Nephrotic? Do you just have to memorize that? In terms of, I don't know what you mean by that. Sorry, I think I didn't see it when you posted the question. But yeah, if you want to just explain a little bit more, Rajika. In the meantime, like the syndromes, yeah, you're gonna have to basically memorize. There's no just the names. There is no easy way otherwise. Yes, so minimal change, FSGS, membranous. These are your nephrotic syndromes. These are the ones that present in the low albumin, swelling, etc. Nephritic generally is everything else, to be honest. You're not going to get anything else like that. You're not going to get tested on a glomerulonephritis, which is not on these slides, I would say. I would hope. I'm not going to say that of conviction, but I would hope. Fine. So the 2 main nephritic syndromes, or 2 of the big ones that can't belong on SBAs, are IgA nephropathy versus post-streptococcal glomerulonephritis. These both typically occur post-infection. IgA nephropathy can be seen as the adult version of IgA vasculitis, also known as HSP, but that's the old name. And you get the presence of mesangial IgA deposits. So if you ever hear that in a question, just think IgA nephropathy. Happens in quite younger people, Asians especially. Again, happens 2 to 3 days after an infection and affects the kidney only. Post-streptococcal glomerulonephritis, however, occurs 1 to 2 weeks after a throat infection, or 3 to 6 weeks after a skin infection. And often the skin infection gets forgotten. So do remember cellulitis as a cause of post-streptococcal glomerulonephritis. Antistreptolizin O titer is raised in a pharyngitis strep infection. So if you've got a throat infection, that will be raised, and it's important to test for. And recovery is usually 6 to 8 weeks, although it's quicker in children and longer in adults. Now, another thing very quickly, last 2 slides, is rapid progressive glomerulonephritis. This isn't a disease in itself, but it's kind of describes a number of disease processes where you've got a very sudden decline in renal function. Can be split into 3 types: type 1, type 2, type 3. Type 1 is anti-GBM, or anti-glomerular basement membrane disease. Remember this triad: glomerulonephritis, pulmonary hemorrhage, anti-GBM antibodies. Okay? If you remember those three, that should hopefully help you answering those in SBAs. If you see linear IgG deposits in any kind of biopsy, that will point you towards that. And it's treated with plasmapheresis and immunosuppression. Type 2 is immune complex, so often post-infectious from strep pyogenes, but also IgA nephropathy can cause this, and lupus nephritis as well. A little bit at the bottom, wire loop appearance on histology is also important. Again, that's just a spot diagnosis. A lot of these glomerulonephritis things, you either know it or you don't really. And often they just tend to be spot diagnoses. The last one is partially immune rapid glomerulonephritis, so small vessel vasculitis, and these are going to be your anchor positive things. So it's going to be your granulomatosis with polyangiitis, or your EGPA, eosinophilic granulomatosis with polyangiitis. Anti-MPO is also an important antibody alongside anchor. That's typically positive in microscopic polyangiitis. And, I'm not going to go into how to differentiate GPA from eGPA here. Vasculitis is horrendous in my opinion. It just takes ages to get your head around. But you just got to memorize it, I guess, and at some stage, hopefully it clicks. That's all from me. Thank you guys so much. If you have any questions, do let me know. I hope that was useful. And let me just post another feedback form. How do you differentiate anti-GBM with granulomatous polyangiitis? Right. So, with granulomatosis of polyangiitis, you're going to have anchor positive antibodies. Whilst with Goodpasture syndrome or anti-GBM, you're going to get your anti-GBM antibodies. Okay, so look at the antibodies. Also, if you've got pulmonary hemorrhage, that's going to point you immediately towards anti-GBM. Typically, these kind of diseases, I won't say no one, but they're very hard to diagnose clinically. You're going to need to do a biopsy, do your blood tests, and that's going to give you the answer. Differentiating between the two, I don't think is necessarily so important. Okay, please fill out the feedback. Thank you all for coming. I hope this was useful. And have a good evening. If you have any questions, let me know. I'll stay on for another few more minutes. And sorry about rushing the end, but we managed to get it in an hour, so that's what matters. Sorry, could you clarify when you fluid restrict and give fluids in the AKI? Yeah, sure. So generally, you need to do a fluid status assessment. That's going to be critical, okay? If somebody is fluid overloaded, they've got peripheral edema, pitting edema in the calves, crackles on the chest and bibasally, and then you may think they're overloaded, they need to be diuresed. If they're fluid deplete, then you would think, well, actually, let's give fluids in terms of, reduced skin turgor, dry mucous membranes, etc. That's when you give your fluids. The challenge comes when you've been diuresing a heart failure patient and they then become They then go into AKI, and that's where you have to kind of use things like urea creatinine ratio, try and work out how we overdiuresed, how we underdiuresed. Is it fluid overload causing AKI? Is it the lack of fluid causing AKI? That is all clinical judgment, really. But the main thing you want to do when you fluid restrict or give fluids is do a fluid status assessment. Is that pre-renal causes? Yep, those are all pre-renal causes. Okay. So typically, you will be giving IV fluids, especially in exams. Just if you want to give it an extra level of kind of understanding, you would fluid restrict in patients with heart failure because it's the overload causing increased preload. And if you remember the Frank-Starling curve, when you've got increased preload and it goes too far, then you've got reduced cardiac output, and that then causes reduced perfusion. How much fluid would you give? Again, that would vary on the fluid status. You won't go wrong with 1 liter over an hour. Generally, if they've got heart failure, then you might go a little bit less. Yeah, I hope that answers all your questions. Can you give 500 ml stat? Yes, you can. It doesn't really matter necessarily how much you give. And then if you're like an A to E, just give 500 ml stat. There's no harm in that, and then reassess. Yeah. No worries. Okay. I'll turn off now. All right. Thank you, guys.